And good morning. It is still morning here in Florida, sunny Florida, at the Deuk Spine Institute. We're getting ready to treat a patient who came to us with back pain, and she's had a long history of back pain. Now, we're going to show you her x-ray, and I don't want any of you to freak out, but this poor patient has had treatment elsewhere where the doctors have done what is becoming more and more common in America, a bunch of unnecessary surgery that ultimately results in more surgery, okay? So let's go ahead and show the x-ray. Can you guys see this, Henry?
Yes, we can.
All right, so she has had fusion done. You can see the cages at L4-5 and L5-S1. So the surgeon went through her belly to put those in. First of all, going through your belly to do spine surgery is extremely risky and dangerous. It should never be done, in my opinion, ever. There's really no need for it. But a lot of doctors go through the belly because they don't know how to do the surgery through the back. So basically, anybody that wants to go through your belly, in my opinion, is already declared themselves as an inferior spine surgeon. There's lots of them out there, mostly orthopedic surgeons, okay? I'm not bagging on orthopedic surgeons. I'm not bagging on anybody, but I'm just telling you the truth. Going through the belly, bad idea. Horrible complications happen. They don't talk to you about it. People lose their legs. They get bowel perforations. They get ureter injuries, kidney injuries, all kinds of injuries that you can never recover from fully, okay? So bad idea to go through the belly, but she had it through the belly. And then they put screws and rods in the back of her spine. You can see those screws and rods there on both sides. So L4-5, L5-S1 instrumented fusion done elsewhere through a combined, not a combined, but a staged anterior-posterior approach. Just miserable surgery, miserable recovery. But that wasn't good enough because she continued to have pain. So then they ended up putting in spinal cord stimulator. You can see the leads, and this is not even the best spinal cord stimulator. This is kind of a shitty spinal cord stimulator, nerve stimulator. These things don't even work. But why would the doctor put them in? Because this is like a B-rated movie. This is like even a C-rated movie. It's a shitty movie, but that's what they gave this patient because that's all they could do. So rather than send the patient for an A-rated movie, they gave him a B or a C-rated movie. So long story short, why are doctors doing this? Because that's how they make their money. And if they can't give you the best, they're going to give you what they can give you. They're not going to send you to another doctor who can give you better because they don't want to lose the business. That's how they make money. And this is just wrong for patients. Patients need to get the best care, and if their doctors can't provide it, they should be sending them somewhere where they can get the best care, like Deuk Spine Institute. So here she is. Today we're going to be treating the facet joints above her fusion. That's the L3-4 facet. Okay, show us that facet. It's a little lower. All right, just a little bit lower, lower. And you can also see the leads for her spinal cord stimulator have been cut because the stimulator doesn't even work. It stopped working and we had to remove her generator because it wasn't working. So the leads are stuck there for the rest of her life, not even doing their job. That's why we don't recommend spinal cord stimulators to too many patients because they stop working. All right, let's get to it. We're going to be treating her facet joints. She's got facet joint pain. Now she has thinning bone, osteopenia, perhaps, and because of that it's hard to see the joints. But the facet joints we're treating are actually lower. Let's show them. Down there, right there. That's the L3-4 facet joint on the right. And then let's go across. And there's the facet joint a little bit to the left right there on the other side. Okay? So I'm going to be zapping the pain nerve where? Yes, 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 yes. 4 spots. And without further ado, we'll get started. If you have questions, feel free to ask us. But this patient has facet pain, and that's what we're here to treat. Let's get a shot real quick. I'll start on my side. That looks pretty darn good. There's num-num or no? Give me some num-num, please. Oh, yeah, tell me in the beginning. I'm going to give you some num-num. Num-num is numbing medicine. It's the same thing the dentist uses on the teeth. Look at that. You know what we call that? Orange peel. When you can make the skin look like an orange peel, you know you're injecting in the right spot. Watch out, the needle's up. We've injected 6 cc's. of numbing medicine. All right, now I've got to get down to that first joint. It's a little too medial. Shot. So I'm going to use the x-ray machine to navigate. We use navigation all the time in medicine. In surgery, you have to use something to navigate. Whether it's a x-ray or a CAT scan or ultrasound, you need some device to help navigate, especially if you're doing minimally invasive procedures, right? Because you don't want to open up and look. You want to do it through a minimal incision. You need to navigate. There's a bunch of different ways of navigating, but X-ray is the most common. Go ahead. So I'm a little bit lower than the perfect spot, about 1 millimeter or 2, but I'm going to get that other area. It's just safer here because I'm on top of the bone. Show us the tip of the needle. Yes. And show us the top of the needle. Thank you. Where's Sarah? Oh, she is? The DON?
Yeah, she's going to get married soon, so.
Oh my gosh,
Yeah,
getting
yeah.
married? I thought we didn't allow that kind of thing at Duke Spine. What is she thinking? Dr. Berndes? Have you had a talk with her? Shot? All right. Does she know that that's not something we're allowing? Marriage? Huh? Right. In between cases? I love it. All right. I can feel the bone. We're in the right spot. Now I've got to just burn. And the advantage of the Deuk plasma rhizotomy is I'm burning right where the pain nerve is with my special tool. I could feel the arthritis. It's massive arthritis. Shot? Yeah. So this patient has a tremendous amount of arthritis. Shot? And it's literally pushing my probe to the side.
So that's the adjacent segment arthritis.
Yeah. Mm-hmm. Let's see, shot. So I want to make sure I get the whole area here really good, because we don't want to have to come back again and do this a second time. Shot? I think that's too low. It is. And of course, before I do any burning, I'm going to verify the position of my probe. Shot? It's too high. Shot? Too low. See how difficult it can be to localize properly, especially when patients have a lot of arthritis. Shot? That feels pretty damn good right there. That's good. That should do it. Pressure. All right, so that's one nerve. Now we got to get the one below, which is going to be difficult. But we're going to need to bring the fluoro towards me and rotate it. Don't take any pictures yet. Pressure. All right, questions from our audience?
No current questions.
Wonderful. Well, we don't really have a video showing why do facet joints hurt. Shot? All right. So it's getting better. Let's see if we can't get a better picture of that TP. No. Let's go. You're going to have to bring it towards me more. Uh-huh. And shot. Rotate it. And shot. Yeah, getting there. More. So the problem is, folks, her spine is extremely scoliotic, twisted. All right, that's almost perfect. A little bit more. You may have to bring it towards me more. Bring the whole base towards me, and then shot. Rotate. So she has horrible scoliosis, which is twisting the spine out of our normal plane. That's pretty good. We need to see, so you can see where the TP, where the superior facet of 4 is, and the pedicle, yeah, that's the superior facet of 4 right there, and come down laterally, a little bit lateral right there. That's going to be my target right in there. Actually, it's going to be a little bit more lateral to that. Sorry, a little bit down, right there. You see the cortical bone of the pedicle, just to the right of your arrow. Yes, yes. So right in that area is my target. Let's go for it. How's the heart rate and everything? Good?
58 blood pressure, 106, 70.
So you happy? Shot? You happy?
Yes, no epi and very happy.
You're happy. No epi, happy. Shot? I wonder if I have to start more lateral. Trying to use the same incision. Shot. It's a little bit better. Shot. It's too high. Shot. These are tough because the twisting of the spine makes it so difficult. Yeah, I can feel the hardware. Shot. Shot. Trying to get it just perfect. That's about as good as it's going to get right there. Okay, let's do some num-num. Go ahead. So what I'm touching there is the transverse process. Go ahead and show them the Scotty dog above. Okay, see the eye? That's the eye of the Scotty dog. See the ear? There's the ear. And then the transverse process is literally there. Yeah, and she's got short ones, but right where the transverse process meets the pedicle, at the top there, right to the left a little bit, left, right, yeah, right around there. Just go to the right a little, sorry. Right there. That would be the target for the level that I'm doing below. So in other words, not that one because we're actually the one below. Don't pull towards you. I need to pull towards me. Yeah. We need to get more lateral. That's the problem. Shot. Looks good. Not there yet, but heading to the right spot, that's for sure. Shot. That's too low. Shot. Let's see where the tip is. Man, what a difficult case. Shot. That's too low. Shot. That's too lateral. Shot. Too medial and inferior. Shot. So it does take some fiddling to get to the right spot. Shot. It's definitely heading in the right direction. That's probably as good as we're going to get it right there. Right there. Unfortunately, we're contending with a lot of scar tissue from her fusion. Shot. So it's not as nice as the last one that we did. Shot. Where we had beautiful anatomy. I can feel the hardware with the tip. It's getting in the way. Shot. Shot. How are we doing, Burndes? Man, it's like screws right there.
Got a good blood pressure.
Huh?
Got a good blood pressure.
Good. I'm trying to It's really difficult because the screw is pushing me. It's like pushing me laterally. I don't want to go laterally. Shot. That should be the right spot. Shot. It's pretty damn close to where we need to be. Just, I feel all the scar tissue, by the way, in this area. I'm hoping that we got it. All right, that's as good as I can do, given the circumstances. We won't know if this works until she starts getting up and doing her normal stuff. But I expect that it will work. It would be a lot better if there wasn't the fusion obviously done. If this was, say, a virgin facet, then I'd feel a lot better about it. All right. Let's take a look at the other side. Shot. All right. So you can see where we need to be, but we're not quite where the fluoro should be, but we can see the target. Shot. No, come on, man. Move towards you. Hold on. Any questions? Shot?
Yes, we have a question from Canes25 on
All
YouTube.
right, thank you. Yeah, good. I'll take the question. We need to get that target better localized. We're close.
And they asked, is there a
Go.
difference in the way facet joint pain feels opposed to disc pain, sir?
Yes. Yes, facet joint pain is definitely different than disc pain. I need you to get that. It's almost good. It's just still you're off. You need to change your rotation. More. Shot. Let's see what happens. All right, it's the other way you need to go then. You're going too much the wrong way. Shot. Give me a second and I'll answer that for you. Keep going. Shot. Oh, so close. A little bit more. I mean, I could probably work with that, but I'd like to get a little nicer. That's it right there. All right, show us the target. That's correct, right there. That's our target. Pretty much where the wire intersects with the pedicle. All right, show us the transverse process. There it is. And the top of the TP is our target, right where it hits the pedicle and superior facet. All right, that's good enough for government work. So to get back to your question, there's several, first of all, there's no guaranteed way that you can describe the pain that's going to tell me it's a disc. But the key differences between disc and facet are number one, disc pain is deep and central, kind of central. Number two, disc pain is generally it can be associated with radiculopathy, which helps, which is, symptoms down your leg. And that helps. And then number three, disc pain typically is located right over the discs, where the discs are that are damaged, causing the pain. And then number four, I think it's four, disc pain doesn't get worse with twisting. Facet pain does. Shot. And disc pain, facet pain is located on the side. Localized, we call it. Coker. It's localized to the side. It's about 2 to 3 finger breaths off of the midline. Okay? Go ahead. That's it. Wait. Right there. Shot. That's perfect right there. Okay, that's our target, by the way, right where we're at. It's beautiful. Knife. Okay. So those are a few of the key distinguishing features. It's the location of the pain, whether it's over the facet or disc, whether it's tender to the touch. You cannot push on a disc area and cause pain. If the disc is the source, you push, there will be no pain. It will be unpainful to the touch. Whereas for facets, it will hurt when you push. It's tender. Shot. But the most important thing is get an expert like me to figure it out. Okay? And the way I do that is with our free MRI review, unless I don't like you, in which case we'll make you pay. Okay? But it's free as long as you're respectful and appreciative. Shot. And then we charge if you're not. But go ahead and put the link for that so people can see it.
Copy that.
Shot. Yeah, it's too high. Right there. Shot, that should be it. Yeah. A little bit higher. I could feel it slipping. Shot. That's the best I can do. Maybe a little bit more medial, but that's it right there. Shot. I cannot get more medial because the wall of the facet is there blocking me. All right, let's see where this is. That's really nice, actually. You can see the wall of the pedicle. Show them the wall of the pedicle there. Yeah. And I'm basically marching along the wall, along the TP, where the TP meets the wall. I'm making multiple burns. Let's see where that is. Hold on. Shot. It's a little lower. Shot. Whoops. Hold on. Shot. Slipped. All right, that's good. That's really good right there. All right, I think that's great. That's good enough there. I felt like I got a really good burn along the junction of the TP and the superfacet pedicle. And now I'm going to try again for this really bad area down below. But we need to first visualize it with the x-ray. And then we'll be done. So as long as we can get this visualized, we're good. Basically, if you look at the screw, it goes into the pedicle, hopefully, if the doctor did it right, which I believe he did. But you can see the pedicle of the L4 shot. Not bad, but I think we can do a little, let's see, that's not bad. I think that's right. Yeah, I think I see it, actually. Do you see it? Yeah, that's right. Maybe just right there. Yep. All right, good. Let's try that. Stay where you are. So normally, folks, we would have the x-ray machine. You want to show the x-ray machine here? You mind showing that, Henry, in the operating room?
The x-ray? Yep.
Yeah.
It's
You
here.
guys see it?
Yes, we do.
Okay. Normally, the x-ray machine would be straight up and down. But the reason it's tilted so much to the side is she has scoliosis. That's really bad. So, and because of that, we have to move the x-ray machine. I think that looks pretty good. I can't really see the tip that well. Let's see. Let's try this right here. Hold on. Shot. Yeah, that's it, right? That looks like the tip there. Right? Yeah, right there. I agree. So that's good. Let's do that. Having the best x-ray machines in the world make a difference in terms of diagnostic accuracy. Because there's a lot of places in here we could do this procedure like burn, but it wouldn't be the right spot. Therefore, the patient would not achieve a therapeutic benefit. So if the doctor doesn't get it in the right spot, then you're not going to get a benefit. Okay? Lateral. So the first and foremost thing in medicine, you have to have an accurate localization. You have to be in the right place. I'm pretty close here. I could feel the screws. These screws. That looks pretty damn good. What do you think, Jordan? Yeah, I feel it. I feel the scar tissue mostly. Okay, hold on. We're almost done. About 30 seconds. We'll be done. Shot. It's definitely in the right spot. What's making it so hard is the scar tissue and the hardware that she has from her prior surgery. Shot, that feels like a good spot right there. I think that's too medial. Shot. And once again, the screw is literally pushing my tool out of the way where I want to be. That should do it. Great job, everyone. Take a look at this, folks. Look how small the incision is. Pull the fluoro out.
Light something. Thank you.
Okay.
Yeah, wait, yeah, thank you.
This is a 3 millimeter incision, 3 millimeters. Right there, right there. That's minimally invasive for you. This is called the Deuk plasma rhizotomy. I'll spell it for you. Deuk. Sorry, it's upside down. Huh? What?
It's on the skin too.
That's all right. You can see the incision here from her stimulator. And then she has also a really big scar like around here from her screws and rods. So we are treating the joints right above the fusion, which are full of arthritis. Hopefully it works for her. All right, any questions? Feel free to type them up. Do we have any questions?
No current questions.
All right, in that case, we're going to wrap up the broadcast. We'll be back for one more shortly.